Hi, good morning, everyone. Thanks for joining us at the Global Neuroscience Institute annual conference for neuroscience. It's an unusual year, but we're here to give you usual care, and actually extraordinary care. I'm really pleased to be able to introduce two of my colleagues from GNI, Dr. Zakaria Hakma and Dr. Scott Strenger. Zach is a dual-trained vascular and endovascular surgeon, and he brings that level of expertise to spine, and Scott Strenger is a practitioner for over 30 years, and he brings that wealth of knowledge to spine. Today we're going to talk about minimally invasive surgical options for traumatic and degenerative spine conditions. And before we really move on, I'd just like to say that spine is one of those things where you might think about, oh, my back hurts, but believe it or not, 80% of the population worldwide will have back pain. And it's one of the leading causes of disability in the United States with regard to both time away from work and also expense in our healthcare system. So, Zach, my back is hurting me. Should I have surgery now?
Not usually. We'll go through the steps of non-operative. Most patients with back pain do not require surgery. We normally start with non-operative treatment, which is medications, physical therapy, time, and that most of the time will take care of it. However, there's some conditions or cases where we would jump to surgery right away if there's associated weakness, foot drop, alarming findings. But for just pure back pain, typically we start with non-operative treatment, and if the patient does not improve, we'll escalate to MRI, X-rays, and pain management and all that. So typically surgery for pure back pain is not the first step, but if it gets to that point, we can discuss what options we have.
Yeah, that's an excellent segue, because I think that there's a situation here on one of our slides that I'd like Scott, if you don't mind, commenting on. And this is, I think, one of those cases where this is that emergency, of course.
And not everybody with spinal pain is the same.
That's right.
The slide that you're looking at is two conditions that we are very concerned about. One is called radiculopathy, and one is called myelopathy. Apathy just means it's not working right. Yeah, that's it. It's right. What's in front of the apathy that's what counts. Radiculopathy implies a nerve root. Myelopathy implies spinal cord malfunction.
Absolutely.
And so with myelopathy, you have spinal cord compression, and the patient may be having signs of spasticity, motor deficit, in addition to sensory, gait disturbance, and that can certainly move surgical options up 100%. The decision process, up the ladder. Radiculopathy is pain in a nerve root distribution. The classic one that patients get are sciatic type pain. They go, oh, I have sciatica. Well, sciatic nerve is one of 3 different nerve roots, and there are very subtle differences in sciatic pain that clue us into which nerve root from the lower back there is. Same thing in the neck with the pain that comes into the arm and hand. And again, it's a question of how bad is the pain? Is there significant neurologic deficit? Can we safely institute a non-surgical course of care? And if we can't, what are our surgical options in terms of dealing with the issue?
And I think all 3 of us have seen in our careers that surgery for the spine is increasingly safer and safer. And I think both of you are going to highlight the fact that it's also getting more and more minimal, which means that the risk to the patient is less, the recovery is less, and the benefit is greater. Do either one of you want to talk how you would treat either the patient slide on the left, which looks like there's some compression in the spinal cord?
Certainly I can. 2, 3, 3, 4, 4, 5, 6. This is a herniated cervical disc that is causing spinal cord compression.
Yeah.
Notice that the disc fragment that is pushed out and pressing on the spinal cord is in front of the spine. Okay? In my father's era, because my father was a neurosurgeon back in the 60s, 70s, classically this was a large, and the expression I like to use is a fillet-fish incision in the back of the neck with wide bony decompression. You would have to lift up the nerve root, move the spinal cord to get to where the problem is. Nowadays, This type of a case we've been doing on a same-day basis for over 20 years.
Yeah.
This is done from an anterior approach where we slide in through the front of the neck, through natural grooves that exist in the patient's body, so it's extremely comfortable for the patient. We get to where the problem is and take the disc fragment out from the front going to the back. So we're actually pulling the disc fragment away from the cord without having to manipulate any of the neural structures and getting the pressure off the cord and off the nerve roots. Then we have to fill in the gap, and there's a variety of ways that we do that with different types of implants, which can be bone, which can be a prosthetic cage. It can be done with an anterior plate to support it, or with integrated screws to hold the graft in place. But by and large, in this day and age, this is a same-day outpatient procedure.
Yeah, and I think that's really important to stress. The other thing I wanted to say to the audience is that as topics come up and questions come up, please bring them to our attention and we'll address them right away so it can be more relevant to what we're talking about. Now, Scott, you mentioned that your dad would have done this in the back, and now you've talked about an anterior approach, which I think is really the approach that all of us as neurosurgeons would use. Zach, would you comment on what are some other safe things that we do intraoperatively? Because I think we can guarantee patients that we know what's happening to their spine.
Absolutely. Overall, surgery has become much safer these days. Starting with anesthesia, we have our own neuroanesthesiologist, so who is familiar with our protocol, our patients, our pathology, and we work hand in hand with her day in, day out. So our neuroanesthesia, starting with just the basic, neuroanesthesia is an important step to keep the patient safe. Then intra-op, we typically use neuromonitoring. So these patients are asleep, but we monitor the function of their nerves and spinal cord. If there's anything going awry or we're putting too much pressure on this or that, we don't have to wait until the patient wakes up and realize, oh, was too deep, or we would know immediately there's something that needs to be adjusted, or we adjust it on the spot before the patient wakes up and realizes there is a problem. So neuromonitoring, I think, is a very essential part of keeping the patient safe during this procedure. Looks like...
Yeah, I was going to ask if you don't mind commenting on this next slide, because this is highlighting what Dr. Strenger was talking about. There are different ways of addressing problems, and I think this might be actually one of your cases, and it'd be great for you to take us and the audience through what you were thinking here and what you afforded them with relief.
Sure. So this is a 36-year-old woman, so very young, very healthy, has no medical problem. She's very active and she loves horseback riding. She fell off of her horse, and I don't know if you have the MRI pictures there before.
Do we have, is this the
Yeah,
MRI?
that's the MRI picture for her, yeah. And on the MRI, you see there's a pretty significant disc herniation. I did not mention her symptoms. She was very myelopathic. She came to me saying, since she fell off the horse a few months ago, she's having numbness and clumsiness in her hand. Her gait was starting to get a little iffy, and she was very concerned about it. And so we sent her to an MRI, and MRI did show a multi-level spondylosis, but most profound was at 3-4 and 4-5, where we see a disc fragment. It's pushing and indenting the spinal cord, causing cord compression and myelopathy. So we had a long disc. Obviously, this patient needs surgery. She's clinically myelopathic. The disc fragments are not as trivial.
So this is what you're talking about. This is something that can't wait.
This can't wait,
Yeah.
and it's already been. I think when I saw her first time, it was already 3 months since the initial incident. So she's already passed the non-operative trial, just given her time. She's tried steroids and NSAIDs, and once we see this MRI, this cord compression. It's something that we should not wait on, especially the patient is symptomatic and she has not gotten any better. So the options for this young person is just like Dr. Strenger said, this is an anterior pathology. Doesn't make sense to go from the back. So anterior pathology, this is a model of the cervical spine. So the spinal cord lives here in the middle, right? So anterior approach allows us to come from the front and attack the pathology directly, as opposed to coming from the back and going around the spinal cord, and that was the old days, but we don't do that anymore. So going from the front is an anterior approach, very safe. The incision for these is literally about this big, and the patient tolerated very well. The pain from these incisions is much less than the posterior incision. The reason being is that In the back, there's all these muscles that cause you the pain after the surgery. In the front, literally, there's no muscles from the front. You make a skin incision, this small platysma, and you directly go into the spine through natural groove, like you mentioned. So the approach for this will be an anterior approach to get these disc fragments off the spinal cord.
And then there's another slide that's up on the screen, and I don't think everyone's going to be familiar with this. So this is going to be something, an innovation that you brought to global neuroscience. Could you talk about it?
Sure. So once just like Dr. Strenger said, once we remove the disc fragment, we have to fill that space with
fill
something.
the gap.
Right, fill the gap with something. And Dr. Strenger mentioned an anterior cervical discectomy infusion with plating. And this is a wonderful operation.
Absolutely.
And you can see here in my hand a model of a cervical spine with a plate on top of it. And there's some screws, 2 on each level, that hold the plate in place. And the space would be filled with a little graft. So it's a wonderful operation, been around for a long time.
But you know, Zach, if you show me that, can you bend that model?
You cannot bend this model, no sir. This is a rigid, fused model. So the idea behind the surgery is to fuse the segment together.
Sure.
So this becomes a non-mobile segment of the cervical spine. So like I said,
But your patient was young.
my patient was young. She's very active. She did not want to have a cervical fusion. And also, when we talk about cervical fusion in a younger patient, you start thinking ahead about adjacent segment, segment disease, the level above, the level below. What's going to happen to that in 10, 20, 30 years? She's only 37. She has a long life ahead of her. So the next option would be, okay, what about artificial disc?
Yeah.
Okay, and this is something kind of coming along in the last few years. And initially it was approved for 1 level, but more recently has been approved in the United States for 2 levels. And the artificial disc is essentially, once you've done your decompression to relieve the pressure off the spinal cord, you're happy with how things look, instead of filling the gap with bone graft and a cage and a plate, you put the artificial disc. And that allow you, and this is the actual artificial disc on this model. And it's an innovation that allow you to retain motion of the disc in both flexion, extension, and also lateral rotation. So it's the only thing it doesn't allow you is actual compression in axial loading. But aside from that, it does allow you to retain motion in pretty much every direction. And this is a model of 2-level artificial disc, the MOBC, and again, allow you to retain the motion in these levels. So as you see on the x-rays there, we have this is our post-operative x-rays. I think this was like 3 months down the road. And you can see the first one is the patient in extension. She's able to bend her neck back. And if we look at the second picture in the middle, the patient is able to bend her neck forward and she's moving across all these disc spaces. So that's worked great for this patient. Now, obviously, it doesn't work for not every patient is a candidate for it. The ideal patients who are candidate for disc arthroplasty are younger patients who does not have a lot of facet arthropathy, degenerative changes, right? Yeah, exactly.
Exactly.
Well, the other thing that's been interesting when the MOBC or other companies' versions of it first came out was that the real question was, would it protect the next segments up? And I believe recent literature has shown that yes, it does.
Absolutely.
Okay, that the risk of adjacent segment deterioration, the so-called marching up the spine, is less with the artificial disc implants.
Well, I think, Zach, you've convinced us that unless we're on Elon Musk's spaceship to Mars, this is the surgery that we want. We've gotten some questions, and one is actually a very nuanced question, so it's coming from somebody that's really thinking about this. This was myelopathy, as Dr. Strenger sort of gave you the quick term. Something's not working when you have opathy. Somebody asked about central cord syndrome, which tends to be something in older adults. Do either one of you want to say how that may or may not look similar? And we don't have to get too far into the weeds, but just how you may or may not even treat it.
Since I'm the older guy, I'll talk about it.
Okay.
The central cord syndrome is a syndrome that occurs when you actually have somebody with these with these significant degenerative changes, bone spurs and things that narrow the diameter of the spinal canal. So take the 70-year-old person that falls in the bathroom and sustains an injury to their neck where they either hyperflex or hyperextend their neck. There's no room for the spinal cord in that narrow canal. And so the spinal cord gets crimped just like it's in a pincer. And the central portion of the cord gets damaged. And that can lead to symptoms of numbness, weakness, predominantly in the upper extremities more so than the lowers. Okay? And this is a true spinal cord injury.
It is.
And it's treated like that. And once again, going back into the day, the question was, did you operate on them quickly or did you operate on them in a delayed fashion? And the current literature suggests that the sooner you get the pressure off the cord and give the cord a chance to heal itself, the better the outcome is going to be long term.
You know, I think as surgeons we find that intrinsically obvious, but I think that also leads into another question that somebody asked about intraoperative neuromonitoring. I think, as you pointed out, neuromonitoring gives you a baseline and can tell you if you're hurting somebody or helping them. And I think now with central cord, with intraoperative monitoring being pretty much standard. Do you use it on all of your cases?
Any cervical thoracic case I use neuromonitoring on.
Anything where the spinal cord is in the field.
Yeah, exactly, 100%. So I think that that probably takes us through some of the questions. There's another slide that's on the that's coming up, and I don't know if that was your case, Scott, or if this is.
No, that's I think it's my case. So I just wanted to talk about what other minimally invasive options. So the first, first operation we talked about is the ACDF, which is a great operation, and we can do better than an ACDF with an artificial disc in the appropriate candidate by maintaining the range of motion, preventing adjacent ligament disease. What other motion preserving operation that we can do without really putting screws and rods and implants in patient is a foraminotomy. And foraminotomy is a surgery that's wonderful, but kind of fallen out of favor for some reason. I think part of it has to do with reimbursement because, a lot of surgeons, to be honest, if they choose between a foraminotomy and ICDF, they would choose the ACDF because the reimbursement is better and kind of fall out of favor. However, in our institution, it's a very routine operation that we do all the time. And in the appropriate candidate, it is a wonderful surgery because it will remove the disc fragment, really, and we're not disrupting the motion and the ligaments of the spinal cord or the cervical spine. In this patient who had a fragment that's really in the foramen, there's no compression of the spinal cord, it's a foraminal disc herniation. So all we gotta do is, and if you can see on the next slide on the x-ray, is make a small incision and dock this retractor over that foramen that we want to expose. All right, so your incision end up being this big. I'm not dissecting the muscles off the spine, so that's where postoperative pain comes from when you move all these muscles around. With this surgery, it's done through sequential dilator. So the first dilator will be something like this. Make a small skin incision, we'll go down on the spine, and through it we'll put another dilator. Yeah, so perfect. So we'll start with something like this. So if you can hold that for me, please, and then
I'll hold this.
And then through these, we'll sequential dilators will go over each other, and then eventually we will put this in place. Then under a microscope, we would go and look through the channel and find that disc fragment, do a little foraminotomy, get the disc fragment out, and you're done. Right? I'm not putting screws, no rods, no hardware, cage, any of that stuff, and the patient are grateful after this operation.
100%.
And again, like anything in spine surgery, patient selection is the key to success. If you choose the appropriate patient for this operation, they'll be grateful forever because you saved them a fusion operation and they're in and out of the hospital within the same day.
So now this was still in the cervical spine, so again, you're using neuromonitoring, is that correct?
Correct.
Yes.
I think some of the audience members were wondering what's involved in neuromonitoring. Is there anything that you change your approach to surgery when either of you, when you're doing a spine case or a thoracic case with neuromonitoring?
It doesn't so much change our surgical approach as it does change the anesthesia technique. Because one of the things that we have to do is, first off, the patient has to be intubated and we have to establish that their neural pathways are intact before we even position them.
Absolutely.
And then, because frequently these patients are unstable or they have significant spinal cord compression, and changing their position can change the dynamics in the spinal cord itself. So we check their signals beforehand, and we're monitoring both sensory and motor pathways. And then once the patient that's established, we position the patient, check to make sure that the spinal cord signals have not been disrupted. And then after that, the patient's relaxed chemically while we do our exposures. And then they allow just enough for us to get there, so that while we're actually working on the cord, we have both motor and sensory functions being monitored. And then once we're done and our final x-rays have been taken and we're closing, anesthesia changes their technique again to facilitate the patient waking up
quickly.
And I'm glad you brought in that last term, anesthesia, because I think Dr. Hakma alluded to this. We have an anesthesia team that's dedicated to our patients, and I think that makes a world of difference in our outcomes.
Yeah.
What do you guys think?
Absolutely. It makes my life easier, the patient's experience in the hospital and during the operating room is easier, because there's not much back and forth. They know our protocol, step 1, 2, 3, 4, and I don't have to say anything, I have to do anything. It's just all protocol. The patient comes in, anesthesia introduced, they use appropriate anesthetics. They know when to wake the patient up immediately after surgery. We don't leave the operating room until the patient is awake, moving everything. If there's a problem, I don't want to find about it, an hour or two later in the PACU recovery room. The patient doesn't leave the operating room until they're awake, moving everything, and then we transfer. So we have all these little protocols that ensure patient safety and experience with us.
Absolutely. So, we were talking about the neck, but there's more to the spine than just the neck. And Scott, when I joined the group, you introduced yourself to me as the old fart. And I think there's something that we can talk about on the next slide, which is osteoporosis. I think the slide shows a woman because it usually happens more commonly in women, but it doesn't mean that men are escapable from this problem.
Absolutely true. Absolutely true. The risk of a woman sustaining a spinal compression fracture in this country once she hits the age of 50 during her lifetime becomes 1 in 2.
Yeah.
For men, it's 1 in 4. So this is very common. It's frequently underreported because people just toss it off as a backache, or the primary care gets a X-ray that says, oh, there's a compression fracture there.
Sure.
Okay, here, take some ibuprofen and suck it up. In terms of their discomfort. If there are over, can we go to the next slide for a second?
Yeah.
There are over 700,000 compression fractures in the U.S. Okay, and only about 1/3 of them really come to clinical attention. There's about 150,000 people per year that wind up getting admitted for pain for this problem. And as I said, it's 1 in 2 for women over 50, 1 in 4 for men over 50. And the question is, historically, again, going back to the day when our population is getting older. And so what do you do with these patients with a compression fracture? Because if you have somebody who's immobile in this age category, they get sick, and they can get sick very quickly. Because of immobility, because get blood clots, urinary tract infections, pneumonias. Unfortunately, the lady that is pictured on this, if you look and see the way her spine is curved, her lung capacity is reduced because of the compression fractures in her thoracic spine, bending her chest forward and reducing her compression fractures. So there wasn't a whole lot that we could do with these patients because we didn't have minimally invasive techniques.
Yeah, and that's a really good point, because initially when we first started this discussion, I asked Zach, well, my back hurts, so what should we do? Actually, in this situation, if I bring my mom to you and she's got a compression fracture, you might have a different story about whether you're just going to do conservative care or not. Is that correct?
Absolutely. We'll evaluate the compression fracture. We don't have to treat every compression fracture with surgery, right?
Yeah.
Still, there is a role for conservative non-operative treatment. However, if the patient is complaining of intractable pain, they're not really feeling better with a brace and all that, I think these days we have a safe technique, safe procedures that we can get them out of the hospital a lot sooner, get them mobile a lot sooner. And there's also literature that shows that if you reduce, when you have a compression fracture, if this vertebral body is compressed, the level above it has a higher risk of having another compression fracture. As you know, osteoporosis is a systemic problem, so it's not just one problem with this bone, it's throughout. So when you have and people studied this, put a pressure probe inside the disc, inside the body, and monitor that if you reduce the compression fracture here, will reduce the pressure and the risk of having adjacent segment compression fracture at the level above. And that's where the newer technology that allow us to expand the vertebral body and restore the height is not just relieving the pain, but also preventing adjacent level compression fractures.
You know, I've got another slide about that. And so now you can see, you know, Zach is the leader of our spine program at Global Neuroscience. And so he's brought us Mobi-C, an artificial disc. And now there's something else that's got this awesome name. It's called?
The spine jack. So the spine, it's a great name, right? It literally is a jack. It's like a car jack. It goes in small, so this is how it goes in. So this is the actual device. The tip of it is the actual device here, and you can see it's small, cylindrical, goes in through a stab incision. So the incision for this is the size of a pen. It's literally 2, 3, 4 millimeter incision, and all I have to do is tunnel this through the skin into the bone, and it's done under local anesthetics. And once it's expanded, like I said, it's like a car jack. Goes from this and expands up. And we have a little video that we're going to show you next.
Yeah, why don't we do that? And let's see, I think I can play this. Do you want to describe what's happening in all the other panes, and then we'll pick up the video?
In the right lower corner, we have the pre-treatment x-ray. And you can see there's a thoracic compression fracture that is lost about 60–70% of the height. So instead of having a vertebral body that this high, now it's like compressed to this degree, and the patient having intractable lower back pain. She can't get out of bed, she's on morphine, and she is pretty miserable. So if you move on to the slide, I'm sorry, the picture above it, this is where you see the spine jack going through the vertebral body, and as it goes in and it's in position, we would open it and the spine jack will expand. And if you can see that, we want to play that video.
I'm going to play the video and then probably take folks through it. Let's see, are we getting the actual video? Yeah, perfect.
Yeah. Okay, so
you'll probably have to see it over there.
Okay, I can see there how the spine jack is in action, where it's lifting, literally lifting, like, again, it's a perfect name, spine jack, lifting the superior end plate higher to restore the height. And once that's done, we'd fill the cement, the space with cement, and that's what you see in the left lower picture here, is after the spine jack did its job, went in, expanded, lifted the vertebral body. Now, to maintain that reduction and relieve the patient's pain, we would fill that space with cement, and that's the end result. And if you compare, you know, right to left lower picture, this is pre and post procedures.
And it's pretty remarkable. It's just like through something as big as your finger.
Exactly. And under local anesthetic, it's under x-rays, and the patient's done in 10–15 minutes, and they're out of the hospital.
And again, it's a same-day procedure.
Yeah.
And then I guess the other question that we'll have is that spine jack is new. There's something, Scott, that I'm sure you can take us through a lot of.
The key is trying to get the improvement in the degree of compression and try to reduce the fracture. And there are many ways to do it. Spine jack is probably the newest of these, and is quite good at lifting the superior end plate. Previous to that, very initially, going back as far as the 1980s, there was a procedure called vertebroplasty.
That's right.
Where you would put basically a needle into the broken bone and inject a liquid cement and glue the fracture right there as it was.
I think we have some pictures that you might have done
Go back
for
to
us.
the prior slide, please.
Sure.
But that didn't do a whole lot for correcting the deformity.
That's right.
So what was developed was a procedure called kyphoplasty, which is done through a similar technique to what you saw with the spine jack, where again a probe is put in, and through that probe is passed a catheter with a balloon attached, and you inflate the balloon to try and elevate the fracture. And this slide demonstrates, you can see the fracture on the left-hand side, and you can see the post-procedure with the cement in the vertebral bodies with some improvement in the height of the fracture itself. And if we can go to the next one, now they've taken that one step further, because like any balloon, it expands circumferentially. But suppose you want to specifically elevate in a direction. So now that they've developed these cannulas where you can direct the expansion of the balloon, this is called a directional kyphoplasty, and you can see in the middle picture of the top row that the balloon is being directed upwards towards the superior end plate of the vertebral body. And again, after you've gotten your reduction, then you insert your cement fillers and fill it with cement.
Right.
So now that is minimally invasive, and some people might even think of it as non-surgical, but it is a surgery. It's done in the OR, but it can be done in other settings. But what happens if something's a little bit, say, more complex?
Yep.
Let's say these, as Dr. Hakma was saying, you have an osteoporotic bone, but that's not just one bone. It's the entire column of the spine.
Always.
And what happens if we feel that there's instability? I think there's some pictures that'll be coming up that I'd love you guys to talk about.
Sure, and I think this is one of your cases. So in this slide here, we see a compression fracture in the lumbar spine, but it's not just compression fracture. This was a little more involved and turned into a burst fracture.
Yeah,
and
I
a
think
burst
we can, on that next film,
Yeah.
there might be a slightly better indication on that MRI.
Right, and you can see on that MRI there that how the lip of the posterior cortex can actually push backward toward the conus and toward the nerve roots. And that will be dangerous, especially if the patient collapses any further. Even 1 more millimeter of collapse, that patient is going to be weak in her legs, can't pee, can't control her bladder. She'll be in a world of trouble. So in this situation, probably it's not enough to do a kyphoplasty or a spine jack. It's probably not going to be adequate by itself. And to be able to reduce that fragment and stabilize that burst fracture, sometimes you have to do a bigger operation. That being said, it can be done minimally invasive as well through stab incision. And as you did in this case, I believe you did a instrumented fusion, but because the bone is so thin, you know, I use the analogy with my patients all the time. When you put the screw in, you know, in an osteoporotic patient, you're almost putting a screw in a drywall versus a stud, right?
Yeah.
So you put a screw in a drywall, you shake a few times, you'll be able to yank it out. That's the same analogy. And to help with these patients, what done here in perfectly excellent picture, it shows that there's around the tip of the screw, you see these black balls. This is cement that is injected through the screw. So once the screw is in, these screws are fenestrated, so you have holes in the tip of the screws where after you put the screw in, you inject the cement through the screw, and this will penetrate through the bone and hold the screw in place. And that's an excellent technique for these osteoporotic patients to stabilize the spine. And also, what we're able to achieve here with the reduction and a little bit of distraction, you're able to pull that fragment away from the conus and the nerve roots, and the patient is protected against further compression. Her spine is stable, and she's neurologically intact afterward.
Now, I would also like to point out, if you look at the picture on the left-hand side that shows the final construct, you see that nice long rod that extends all the way from top to bottom. And classically, that would require a long midline incision, a lot of muscle dissection, tissue damage. It would be a very painful procedure to put an 81-year-old woman through. In this particular case, with the minimally invasive techniques, the screws that were put in by you were all put in percutaneously through small stab incisions. And then, under X-ray, you're able to thread the rod through the connections that we have.
I don't think we have a model.
We don't have a model of it here,
Yeah.
but basically, the screws have long posts. And under X-ray, you can thread the rod from top to bottom, lock it down, you can get your distraction, and all of this can be done through a series of 8 small incisions that big.
Yeah. No, I think that what this does is, in my residency training, I'm sure, Zach, it was the same for you, and Scott, I'm sure even more so for you, if you would have ever suggested a 70 or an 80-year-old getting a spine operation.
Osteoporotic?
Yeah, I think you would have been laughed at and
Yes.
maybe called other bad names.
Yes.
We've all been called bad names in residency. But I think that this really extends the treatment window of folks that we can help tremendously. Don't
Absolutely.
You think? Yeah, absolutely. So let's see. We have somebody ask a question, and Zach, I think you're probably the optimal person to answer this. With regard to a fracture, how long now? Remember we were saying, well, back pain, no big deal, but a fracture, when do you either do a spine jack or ask Dr. Strenger to do kyphoplasty?
Yeah. I mean, do you want to talk about that kyphoplasty?
From my standpoint, A lot of this depends upon the pain the patient is having.
Yeah.
The literature is frequently that the earlier you do the procedure, the better the result. Okay,
Yeah.
because you're not dealing with bone that's been partially healed in,
Absolutely.
et cetera. Okay, but it really comes down to the patient and what the patient's pain tolerance is and whether they find their current quality of life
Right.
acceptable. When the patient is ready to, that's it, I've had it,
Yeah.
then we look at the anatomy of the fracture as it is then.
Yeah.
Because once the compression fracture occurs, there's nothing that can potentially keep the fracture
Sure.
from progressing.
Absolutely.
Correct.
Okay? And if you look at the literature on this stuff, if you take two patients with the same compression fracture, one heals naturally, one gets augmented.
Yeah.
You go out 2 years from the time of the fracture, both patients feel about the same. The difference between them is that the patients who get augmented tend to be more active, tend to have less medical complications from inactivity during that 2-year period of time because they get their pain relief earlier than
Absolutely.
the ones that heal naturally.
Yeah.
Yeah, and I completely agree. I think the sooner the better after the compression fracture. After 2 or 3 months, it may not be as effective in relieving the pain. And like you said, the bone will be settled, it will be hard to lift it back up. So if the patient is admitted yesterday for the compression fracture, I will see him the same day and probably the next morning, see how they're doing with their pain control. If the next morning they're up and around, they're minimal pain, and there's no need for it. If they're still in bed, they're on narcotics, morphine, they can't turn around, they're in horrible pain, I would do it before the patient leave the hospital. So in my opinion, the sooner the better.
Now, we talked about how back pain is one of the leading causes for people to actually see a physician in the United States and even globally. And when we think about the back, we know that it goes from the back of the head to the top of our hips. But really, there are 5 bones, the lumbar spine, that I think dominate most practices in neurosurgery.
Especially at L4-5.
Yeah, exactly. No matter where you are. And there is there's a notion of back pain being a witch's brew of problems, of patients that say never have spine surgery, patients that love their spine surgery, asking what's the latest innovation in spine surgery, from the artificial discs in the cervical spine to just fusions. And I think we're going to get into that. But I think what I'd like you to take us through is this next case on this 46-year-old woman.
So like I mentioned, spine herniated discs are a very common problem. This is a 46-year-old woman I saw in the office. She already had 2 previous lumbar microdiscectomies over the course of the last 10 years. And she came to me again with a horrible L5 radiculopathy. She couldn't walk, she's sitting uncomfortable, she's already on narcotics. And on top of it, she has this chronic lower back pain. So she has 2 components, the sciatica type pain, the radiculopathy, and the mechanical back pain. And if you look at the MRI there, what you see at the L4-5, where the discectomy has been done, you can see what we call modic changes, or essentially it's edema in the bone. How we see how around the disc space at L4 and L5, it's white, and that's because of the loss of the disc space that allow us to cushion the movement of that joint. And that's one of the leading causes of chronic back pain. And the fact that she had previous 2 lumbar microdiscectomy, and this disc herniation, as you see on that left slide there, it's literally in the foramen underneath the facet joint. So another microdiscectomy is not going to be an effective treatment for this patient for a couple of reasons. One, it's not going to address the chronic back pain that she had from having her disc taken out twice before.
Yeah, of course.
And for me to get to that disc space, I will have to essentially remove that facet joint and destabilize the spine further. So to address this, in the old days we would do an open laminectomy, decompression, discectomy, which essentially end up being an incision about this big, and especially in bigger obese patient, the bigger the patient, the longer incision to get down to the spine. And the patient's in the hospital for a week or 10 days, pain control, PCA, morphine pumps, and they can't move around. It's a big, not terrible, but it's a big operation. So
it scares people, doesn't
it? It does scare people, and that's where you hear some of these horror stories about patients not getting better. Patient selection is essential, but also the surgical technique and what type of surgery the patient had plays an important role in it. So what we're doing now, especially for 1 or 2 level surgery, is minimally invasive. So we're taking that incision that is this long and making it this long.
It's kind of a version of that tube retractor, isn't it?
Exactly. So what you see here is that similar to what you see on the picture is a tube that would start with a small incision, and through that small incision we would start to, so if you would hold that model for me, okay, so let's say I want to do a TLIF on this side. I would start with a small incision on this side, dock this tube down, and once that's docked, dock another tube over it, hopefully, we'll get this thing. And once that's in, we'll be able to put this big contraption through that small incision. And that will allow us to work on the spine by opening this retractor. Well, that's what you see on that picture there. So this is what minimally invasive TLIF, or TLIF stands for transforaminal lumbar interbody fusion. So we're doing this whole operation through this little tube, through a small incision. And what we've done in this case is, going through that tube, remove that disc altogether. So we're not dealing with any further herniation. The disc is gone. There's no more herniation because we took out the entire disc. And what I put there at that level is an expandable cage. It's a newer technology too that will allow us to put bigger devices into a small incision, small holes. So it'll be less. Thank you. So it'll be less distraction, less bony work, less incision, because the actual device is going in small. And once it's in the disc space, as you can see in this picture, it expands inside too, and it does lift up the disc space and restore height a little bit better. And once that's done, we'll lock it in place with a couple of percutaneous screws, and that's what you see there on the wire sticking out from the retractor. These are the K wire for the percutaneous screws. So,
and I think your point about the right patient and the right technology and the right time, maybe 20 years ago, it would have been a bigger, morbid surgery.
Yes, and in point of fact, it's not just the technology here, it's also the pharmacology that's gotten better. For example, in the older days, pre-2000s, pre-2010, you didn't have the long-acting local anesthetics like Marcaine and things like that. And now we have Exparel, which is a truly long-acting local anesthetic. And so you can literally have these patients up and moving around very rapidly after their surgical procedure because you've infiltrated the entire area with long-acting local anesthetic.
Now, do either of you put any limitations on your patients post-operatively, or how do you handle that?
So there's no cookbook for everybody, right? Everybody's a little different.
Sure.
So in a patient like this, for example, patient, right? She's young, she's 46, her bones are solid, it's a solid construct, minimal restriction. I don't use a brace. The only thing, maybe she don't go doing heavy lifting for a few weeks afterward, but aside from that, there's no restriction. She's going home the next day, no drain, no restriction from driving as long as she's not on narcotics. So really going back to normal life as quickly as possible is the key to success here.
That's the philosophy.
Yeah, I agree.
I think we had a question from the audience.
Well, there's a question about artificial disc, and I think that artificial disc, I was going to come up to that later, but unlike what Dr. Hakma showed us in the cervical spine, I think the notion of artificial disc in the lumbar spine is certainly a wonderful one, but maybe either of you will tell me what your thoughts are and also historically where we are.
I mean, to be honest, the results have not been as good as cervical at all. I actually have done lumbar artificial disc years ago with the original Charité implant. And there were not only unsatisfactory patient outcomes, you would still get fusion across the disc space. There were some disasters where the implant would eject and could damage intra-abdominal contents. And so by and large, I think the mechanics of the lumbar spine are different 100%. From the neck. Absolutely. And therefore, it's not as good a technology as it is up in the neck.
I mean, these days they're really not standard practice. There are some studies and investigational trials that are enrolling patients in artificial disc, but for the majority of the cases, it has fallen out of favor. We did it when I was training, and it kind of fallen out of favor. And they're still trying to optimize the technology, but we're not there to make it a standard of care like the artificial disc. Also, the approach to put this in is, this incision, it's in and out in no time. For the lumbar spine, you have to open the abdomen.
Absolutely.
It's a transabdominal.
That's a big
You have
deal.
to open the
Yeah.
you have to open the abdomen. You have to move the major abdominal vessels
So-
to get to where you want to go to put the implant in, and that can be a significant issue.
I think basically nobody wants an artificial disc.
In the lumbar spine, yeah.
Correct.
No. Well, that doesn't mean that technology is not going to evolve. But right now, I
Yeah.
would disabuse anyone of the notion of thinking about artificial disc surgery.
Absolutely.
You know, the benefit that we have with you being here, Zach, is not only are you the leader of our spine program, but you're also a vascular surgeon.
Yes.
And the question in a very typical sort of fashion, because you deal with strokes all the time.
I do.
And so TPA are 3 words that you know, or
Yeah.
letters that you know very well.
Absolutely.
And so what about if you have, we're talking about older patients,
Yeah.
older population,
Yeah.
they're also going to have strokes. So
Sure.
what's the story there in terms
So-
of how can you treat them?
After minimally invasive
Yes,
surgery, right?
that's right, yeah.
So the one thing is minimally invasive surgery doesn't mean it's not surgery,
Yeah.
right? So on the outside it doesn't look like it's much. On the inside, it is as real surgery
Yeah,
as
yeah.
the open surgery.
Yeah,
It's just
exactly.
it's not the term that we use more is minimal access surgery,
Yeah,
right? So it's
that's
not
true.
minimally invasive; it's minimal access surgery. So on the inside is as big of a surgery as a real surgery. So if the patient had a kyphoplasty, it's one thing, probably should be okay to give a TPA. But if the patient had a T-lift or D-lift or another minimally invasive surgery, I would not give TPA because on the inside it is still a real operation. So it carries the same contraindication to TPA like any regular open surgery.
Yeah, no,
Yeah.
fantastic. Now, there's more technology that you're bringing to us, Zach. And again, I think it's because you lead our spine program.
You keep saying that.
I do. But it's true. I mean,
Yeah.
you brought a lot of technology to global neuroscience, from the artificial disc to the spine jack. There's something else, and you slipped when you said it. You said D-lift, and
Yeah.
I think that was your prelude to this.
Okay.
So why don't you start talking about what that alphabet soup of letters means?
So D-lift is multiple.
And there's another
yeah,
scan that we can look at, too.
multiple names for the same thing, but I use the term D-lift the most. It essentially stands for a direct lateral interbody lumbar fusion.
Yeah.
And the key is it's direct lateral. And there's other terms for X-lift or extreme lateral. They're all the same. It's the same surgery essentially. And it's a wonderful operation because, believe it or not, this can be done very quickly.
Yeah.
And this is more appropriate or gets you better results quickly in older patients and obese patients. You get to do your work and put bigger cage, bigger distraction in relatively, I would say, per level, I quote my patient about 20-25 minutes per level for these for the D-lifts. And so what is D-lift? So let's get a spine model
I think
here.
you got a model
Yeah.
right
Oh, we got
there
actually
with-
we have
yeah,
a D-lift
exactly.
model
You
with
have a
D-lift on
D-lift,
it, right? Okay. So it's the same principle. Patient is as you see on the next slide, for example, right? So on the cartoon picture there, you can see the demonstration of the surgery. The patient is on their side. An incision, again, you can see the picture of the incision there. And through the incision, we will put the dilators, and these dilators will go through the psoas muscle. Now, as we all know, the psoas muscle has a lot of nerves inside the
does.
lumbar plexus.
That's right.
And that was one of the major reasons this surgery did not exist in the past, because people were like, well, how are you going to go through all these nerves and plexus that lives in the psoas muscle? Well, the key is neuromonitoring. So the way it's done is that you go down with the first dilator that is already attached to a neuromonitoring probe. Okay, so this is connected inside of it, right? And it's connected to neuromonitoring. And once it's docked, I'll be able to tell, am I next to a nerve?
Yeah.
If I am, okay, let's move forward a millimeter. Let's go back a millimeter. Once you find a sweet spot, you dock your retractor, you put your K wire, and sequentially put the dilators until you're working through this channel. Once done, this is the easiest operation because you're directly on the disc. You have a wonderful window. You're only looking at the disc. There's nothing else around it. You go and do a full discectomy and put this biggest cages that you cannot really achieve from the back. And that's going to be the key from the from the side, is that
Absolutely.
you cannot really put this from the back. I mean, this is a huge, you can't really put this
No way.
spacer from the back. This is what you can achieve from the lateral aspect. And you can have different lordotic cages. So if the patient is straight or falling forward, you can put lordotic cages to kind of bring them back up.
So you feel like you can match the biomechanics of the patient much better.
Much better with
Yeah,
this because
sure.
you're able to put a bigger devices in there as opposed to going from the back where you have to walk through between the nerve
Narrow
roots.
corridors,
narrow
absolutely,
corridors, yeah.
absolutely.
So,
Do you want to explain just a little bit as to how you pick a patient for DLIF? Like what would...
So let's go back to the previous slide. Okay, so for example, this patient has a 4, 5, 3, 4. So 3, 4 anterior listhesis with severe foraminal stenosis. I'm sorry, central canal stenosis. You can see the bone kind of slipped forward and the central canal is tight. This is a 55-year-old, relatively obese. You can see all the whiteness around the spine. It's all the fat. And what happens is that this patient, every time she stands or tries to walk more than a few minutes, she gets this leg cramp. She cannot walk more than a few minutes without getting what we call the neurogenic claudication, right? Because the patient is getting the cramps in the back of the thigh. They tend to walk a little bit better when they're hunched over or over a shopping cart or something. So she's pretty miserable with this. The key for this, what makes this a candidate for DLIF, one is the disc space is very narrow. So disc space has to be very narrow. You can't do this surgery in disc space that's already full because you're not able to jack them up. The disc space has to be very narrow. So when you put your cage and shavers in there, you're able to restore the height. Once you do that, you're going to stretch out the ligaments, stretch out the space, and you resolve the central stenosis. So it's called indirect decompression, right? So that's the difference between going from posterior, we're actually doing direct decompression of the nerve root, and this is indirect decompression, and it works wonderful in the correct selected patient.
But let's also make sure that everyone understands that there's back pain that's involved here too. But that back pain, Scott, that's not something that you're going to do kyphoplasty on, is it?
No, for this.
No, exactly.
No.
I just want to make sure that people understand that.
The augmentation procedures are for fractures.
That's right.
As opposed to this.
That's right.
I mean, we were just reviewing a case very similar to this just prior to our session here, where I have a 61-year-old with very similar findings at L3-4. She's had a prior fusion at L4-5 7 years ago.
Yeah.
And now you're dealing with a reoperative spine and how to get the patient decompressed and restore their height and their alignment.
Well, the reason why I asked that question is because there was a question from the audience about when would you not do kyphoplasty or spine jack, and I think that you would not do it when it's not indicated.
That's
right?
correct. I mean,
because
the indication for kyphoplasty and the augmentation procedures is pain.
Yeah.
Okay? If the patient is having incapacitating
But
pain.
not this type of
Correct.
pain. Yeah.
No, those are for fracture
That's
pain.
right.
How about age?
Age?
Yeah.
Oldest one I've ever done is 99.
That's exactly right.
And I discharged her from my practice 1 month post-op. She was fine.
So age is really not a contraindication
no, not
because you
at
can
all.
have an older patient that's healthy and tolerate these minimally invasive 15-20-minute surgery as well as anything.
And also, when they're younger, youngest patient I've ever done is 39. How does a 39-year-old get osteoporotic?
Well, that
Because
happens.
they're on chronic steroid therapy
Exactly.
for a malignancy that they have elsewhere.
Of course. So then for the DLIF, is there any contraindication, or are there other things that you'd like to talk to us about? I don't know, in the next picture, is that...
So that's a post-op picture from the DLIF. So you can see
But
there.
is that just the DLIF?
So right. So this is the same patient that we talked about. And on the first picture on the right side, you see the pre-op where the patient slipped.
That's right.
And the next two on the left, it's the post-operative. So what you see there is the cage inside the vertebral body, right? That's the two lines standing up.
That's
but
right.
On top of it, there's a posterior supplementation, and that is done minimally invasive as well. So once the cage is in, we flip the patient and put these perc screws. Again, that's not really open surgery; it's minimally invasive surgery. There's sometimes where we do standalone DLIFs, and this will be an example of it, where the DLIF comes in with its built-in plate from the side, where would you put the cage in, and through the same incision, through everything, you put the screws in at the same time. It all depends on the biomechanic of the spine. Again, not every patient is the same, so it's not one script fit all. If there's significant instability and the patient is mobile, I tend to go and do a more stronger construct from the back.
Sure. Yeah.
But if there's no instability, I just need to jack them up, restore the height, this will be perfectly fine.
Yeah. Now, we'd be remiss, we're sort of winding up on the spine talk, and the spine, as we said, goes from stem to stern. And we've talked about a lot of fancy toys and instrumentation and cement and things like that, but still, day to day, what probably everybody needs, take it back. Not what everybody needs, hopefully you don't, but the most common operation that we probably provide to offer help for what you called, again, the opathy, radiculopathy. Compression on the nerve root is what, Dr. Strenger?
It's a lumbar microdiscectomy or a
That's right.
microforaminotomy.
That's right.
And the cartoon here, this is an operation that me personally, I've been doing on a same-day basis since the mid-1990s. It's done through a tiny little incision in the back. We put in dilators just like you've
You use those
demonstrated.
dilators, right?
Right.
Yeah, exactly.
Okay.
That's right.
All right. Originally, the dilators were developed as an endoscopic tool, and we actually had a surgical endoscope that had a little angled thing where we would look up on a TV screen. And people very quickly realized that the advantage of that was not the endoscope. The advantage
That's right.
was the dilator
Yeah,
system, was the
100%.
tube.
Yeah.
And so then they said, why should I look on a TV screen? I'll take a microscope, I'll look down the tube.
Yeah.
Okay, and that led to the way we do microdiscectomies now. You make a small window in the spine, you move the nerve away from the disc fragment that's tossed out, you shave off the disc, you clean it up, you close up and go home, and the patient goes home that day.
And these are the most grateful patients.
Oh my,
Oh my
gosh,
God, yes.
Yeah. These are the ones that you get Christmas cards from.
Yeah, exactly. They go to sleep, they're in tears, they're crying in pain, they wake up, and like, I don't feel my leg. The pain is gone, right?
Yeah.
Right, the leg pain's gone, they're a little sore in the back, and again, the newer local anesthetics have almost abolished that.
That's right. Yeah, yeah. These patients, they wake up thinking you're a genius, and you go home and your kids still think you're an idiot. Yeah. I think that there's I don't know if there's anything that you want to really take through on this, aside from the fact that, Scott, why don't you tell us about the age of this woman on the...
Well, this one's 76, and I think this is also one of Zach's cases, but I'm not sure.
Yeah.
I'm pretty sure it is. But again, one of the biggest problems we see is lumbar stenosis, where the patient has these leg pains, the claudication.
Yeah.
This is the patient that races their spouse to the shopping cart in the supermarket.
Yeah.
Which one of them is going to get it so they can lean forward
That's right.
and they catch themselves a break because their spine opens up. It used to be, again, back in the day, we would make large incisions, do a big decompressive laminectomy,
absolutely.
a lot of muscle and ligament dissection.
Yeah.
Okay. Nowadays, again, using the minimal access system and a microscope, we can do that same type of decompression. That's the image on the upper corner.
Especially in patients who have a little bit of spondylolisthesis, right? So if they have a little bit of spondylolisthesis, but it's not dynamic, flexion extension doesn't move too much, but you worry that if you do a full laminectomy,
That's right. You're going to destabilize.
with a full laminectomy, what do? You remove literally the entire posterior elements. You remove the spinous process, the lamina, but more the ligament. So you're going to take this patient that had a really static spondylolisthesis or a little bit of slip. Now you're going to make him into unstable.
And
So
doing
that-
them to a fusion.
and then they're going to be in fusion. So this is where I use this quite often in patients who are a little older, who have a little bit of a slip, and they don't want to go through a big fusion, and they don't need a big fusion. All they need is a little bit more space in the porcine canal, and this is what you can do through a tube. And this is, you can see at the bottom left, pre and post-op level of the spinal canal. You can see
how it's open.
on the left side, the spinal canal is very, very tight. There's what I'm looking at is the whiteness in the circle there, and on the right side, that white circle became much bigger.
Well, gentlemen, we're really rapidly approaching our finish, so we're going to have to extubate the patient, and I'll head to the surgical lounge. Now, I think we can talk about one thing very quickly, and that is somebody asked a question about traumatic compression fractures anywhere throughout the spine. I think they're all open to minimally invasive techniques, aren't they?
Correct. So the compression fracture, the highest I think I've done was T4 in the thoracic spine. Above that, the pedicles becomes really small to put these cannula through it. So for kyphoplasty or spine jack, I don't know if you've done higher than T4.
No,
T4
the
is
highest
probably-
I've done is T4, although it's approved to T1.
Yeah.
The highest I've done is T4, and I've done every level all the way down through.
Yeah,
Yeah,
I've
yeah,
even
so-
seen some people use it in the cervical spine, but direct.
Direct, yeah.
So, I mean, I think that the bottom line is that we have toolkits,
Yeah.
and we come to the job, and we use that
You just
toolkit
pick
for whatever is
whatever.
appropriate.
Exactly.
There's a final question that I think one of our participants is picking up on, and that there's smaller and smaller openings and more minimally invasive technologies.
Yeah.
And I think, Zach, again, you're the perfect person here because you also deal with our vascular side of diseases.
Yeah. And this is the
What's
analogy.
open for that? Yeah, exactly.
I mean, the analogy is for cerebral aneurysms until recently everybody with the aneurysm had a big craniotomy and we had to
Absolutely.
clip it and all that, and the patient will be in the hospital. Now we're going through the groin, coil the aneurysm, the patients are gone in less than 24 hours, they're home. So this is what we're trying to bring to spine surgery, is take these big whacks, big operation, make them as small as possible.
Absolutely.
And it's better for the patients, better for the healthcare, better for the cost. And you know, if this was my back, I don't want that midline filleted open incision. The smaller I can have an incision, the better. I'm home the next day, up and around. And
I think we can highlight at Global Neuroscience, we're always looking for using more minimally invasive techniques for more maximally beneficial outcomes.
Agreed.
I think that I really just can't begin to thank both of you for being here. I think it was an hour, so we could have gotten through 3-level D-lifts for you, Zach. But as it is, we'll just say thank you to everyone and goodbye.
thanks, everyone.
Thank you.